Good evening, everybody. Thank you for coming to tonight's program. For those that don't know, my name is Stuart Schlossman, and many of you do already know that I'm president and founder of MS Views and News. And what do? Well, we provide educational programs. We do that on the internet. We do that live in programs in person. We started just in the state of Florida. We now get outside the state. We do programs in Atlanta. We do programs in Birmingham. We do programs in both of the Carolinas. And this year, we're also doing programs coming up in the next couple of months in Chicago and in Indianapolis as well. So, yes, thank you. So people there, they see what we're doing. They hear about it on Facebook. They see it on Twitter. They want to know why we're not doing these kinds of programs in their areas. And so we're trying to get out. We're trying to get the grants to do these programs in other places. So last year, by the way, firstly, this is our third program of this year. Last year we did 40 programs. It's pretty amazing when you think that there's only 52 weeks in the year. How did we do 40 programs? But they were done and it worked out great. And so we're going to go forward and we're going to try to come close to that number this year. But it is exhausting. And so we do hope that everybody is educated. All right. So again, we did all those programs last year. We had many people watching it on YouTube. We were able to reach that many more. So it was the amount of people that attended our programs, 40 programs. We averaged 67. We had over 2,600 people attending our programs, plus the 14,000 that watched the video channel as well. Tonight's program is sponsored by Teva Neuroscience, and we want to thank Teva for giving us the funding for doing tonight's program. We'd like to thank Judy over there. She's very good and instrumental at helping us do tonight's program. We also want to thank Mallinckrodt, Biogen, Accorda, Genzyme, and a few of the others that were here tonight or were not able to make it. We'd like to thank them as well. Also, this program tonight is was designed for women. So, you're going to hear some general things that affect men with MS maybe, but primarily for women. And so this program, Women's Health Issues with MS, we did it in Jacksonville a few weeks ago. We're doing it tonight. We're going to be doing it in Miami in a few weeks as well. During the Q&A, we will ask that all the men that are in the room please vacate the room. That includes me. That includes our videographer as well. Okay? We will leave the room so that way the women can ask their questions, feeling like you're confident. You don't have to be embarrassed that there might be men in the room. Whatever it is, ask. The cameras will not see you. They won't see you at any other program either. We will hear your voices. You want your questions so that way other women in the world can possibly hear what you're questioning and get those answers. All right? Please wait for NIDA and Michelle to get around the room with the microphones. If Michelle can't do it, then somebody else will step in. Please wait for that microphone to get to you because the audience that's going to be listening on YouTube cannot hear it unless that mic gets over to you. Okay? So please just wait for that mic. All right. So I don't want to take up any more of your time. I want to get this started. So let's get this started. Let's thank Patricia Pagnotta for coming in from Orlando tonight and helping out with this program. And thank you.
Well, thank you all for coming out. And it's been a little bit colder in Florida. So it's going to get cold again tonight. So again, thank you for coming out. And I hope that you get a lot from this program. We are going to speed through a lot of information. So I encourage you, please, go back to the YouTube, ask questions, take notes, because there's a lot of information here. I could cover each one of these topics in several hours to a whole day seminar. So you're getting like speed. So tonight's program is What Do Women Want to Know? And so we're going to cover current therapies. We're going to cover that pretty quickly. Parenting and the impact on family, nutrition, intimacy and sex, and self-care, which includes attitude and empowerment. So, getting straight A's. If anyone knows me or has heard me speak before, I talk about the report card for MS. And so we all want to get straight A's, right? When we're in school, we want to get straight A's. We want in our job performances to get straight A's. So to get straight A's in multiple sclerosis, we would like to think that we could get persons closer to disease freedom. Disease freedom means that for at least a period of time, you are not having any MRI lesions, new lesions, lesions that get larger, or lesions that change and become part of atrophy, black holes. that you're not having any relapses. So you are free of acute symptoms that come on and interfere with your function and then may get better or may not get better. And you're also not having any disease progression regarding, bless you, disability. So what function you have maintains the same. So your ability to do the things maintain the same. Not that you shrink your world so that you can continue, but that you are able to do all of the things that you want to do, and that maintains the same. And so that should be what, when you're before your healthcare provider, those should be the things that should be addressed at every appointment. Are my MRIs stable? Have I had any relapses? And am I the same functional state that I was the last time I was here? Those should be the things that you should be prepared to talk about. We now have 12 FDA disease-modifying drugs. Wow. When I first started, we didn't have any. And so now we've moved on to 12. The first one to come out, you can see the timeline up here, but beta-seron was the very first to come out. Then we had Avonex, Copaxone was right behind there, Rebif, and Extavia came much, much later, but really Extavia is beta-seron. So we have the interferons. We have a new interferon that came to market. That's called Plegridy. That just came to market this year. And so the interferon class are those drugs. And then we have Copaxone. Copaxone is different than interferon. It's been around for nearly 20 years. And those we would say are, quote, injectable medications, or potentially what some persons may refer to as platform medications. And then we have the explosion of the oral drugs. Gilenya was the very first oral drug to come to market. Aubagio was not long after that, well, actually a year and a half, almost 2 years after that. And then right after Aubagio came Tecfidera. Along the way, long before all those drugs, we started having some infusions. Novantrone was the very first infusion to come out, and then we have Tysabri as an infusion, and the last infusion to come out is Lemtrada. So if you look at these placed in category of not the timeline, but the type of medications, persons typically will come in the office and ask me about, well, is it injectable medicine, is it an oral medicine, or is it an infusion medicine? And you see the separation here on the slide. The injections, the self-injections, all the interferons are listed there kind of together. And then you have Copaxone. So the mechanism of actions of those drugs and the side effect profile are a little bit different. The side effect profile of the interferons are very, very similar. You can get flu-like side effects from the interferons. Typically, they're well managed with pre-medication. Some people say that they last a little bit longer than the average, but for most persons, they do resolve in 3 months or so. You can have injection site reactions in anything that you inject. With the interferons, we have to monitor liver enzymes, and you can have neutralizing antibodies and things like that. There's other things with the interferons. We have to worry about potential depression. Depression is a big part of multiple sclerosis, but that has also been linked to interferon use. That's not an exclusion, but it's something to consider. We watch persons' blood counts. And there's the incidence potentially of seizures on the interferons, which is a very low incidence. But, these interferons have been out. Again, these drugs have been out for, going on 20 years. So we have lots of safety data with these drugs. So the list, if you were to look at the potential side effects with these drugs, and we say they're safe, you would look at the list and say, oh, but we think they're safe because we've been using them for so long, and we know how to manage them, and we know what to look for. There's nothing that surprises us with the interferons. We know what's going to happen. It doesn't surprise us. The same with Copaxone. Copaxone has been around almost 20 years. The beauty of Copaxone is you don't have flu-like reactions. So the burden potentially, if you're one of those persons that has a more hyper flu-like reaction that causes you to be fatigued or medicate and whatnot, you don't have that problem with Copaxone. There's no flu-like reactions. You can still get injection site problems. It's a subcutaneous injection. You can still get some injection site reactions. But the beauty of Copaxone, many of you in the room may know, Copaxone up until recently was a 7-day drug. You had to give yourself an injection every single day. Well, Copaxone has gone back to the drawing board, relooked, did another study, and now has a 3-time-a-week drug. So it's a double concentrated drug. It has been proven to be just as efficacious as the original Copaxone. They did not do a head-to-head trial, but the efficacy looks just as good as the pivotal trial with Copaxone. And in fact, they have in the new trial more MRI data that they didn't do with the original Copaxone trial because, you know, MRIs were not as powerful in proving to the FDA the efficacy. So it wasn't part of a standard trial way back when. The other injection issue potentially with Copaxone that I like to make sure persons all know, it's extremely, extremely rare, but you can get a post-injection reaction where you might feel a little short of breath. You might feel like your neck is constricting a little bit. You might feel like you're having chest pain. The beauty of it is those are all pretty dramatic if they occur to you, and I tell persons, well, it doesn't last. It only lasts for minutes, maybe up to 10 minutes. But it's pretty scary when it happens. And so some people that have been on this drug for years have never, ever experienced that. Some people have reported they've experienced it more than once or twice. So it's just, again, a very variable thing, and it has nothing to do with the injection technique. It is just a phenomena that can occur, and if you know that it can occur, then you're not scared by it, and you don't call 911 and worry that you're having a heart attack or something. So again, very safe, and it's been around. So all those drugs, again, for many people, have been proven to modify their disease for a very long time. I have some patients that have been on every single one of these drugs and have stayed stable on these drugs for a very long time. So I try to encourage persons to think about MS as, again, a marathon, not a sprint. This is a lifelong disease. This is a chronic medical condition. So we really need to manage it as such. And I encourage persons to think about that. So I don't want to be flying through drugs and think, well, I won't have the opportunity potentially to go backwards, depending. So I like persons, as a rule, now there's always exceptions to that rule, but to kind of try to consider to start on one of these safe, proven medications and then follow and see how we go along and potentially then change. The oral drugs have come out, and you know that is a challenge because a lot of persons will come into the office and say, well, I want an oral drug. I don't want to inject. I want an oral drug. And so, you know, we go through that. And, you know, I tell persons the 3 A's that we talked about, everybody remembers? Disability, relapses, and MRI activity. Well, the 4th A is, can you take your medicine? Adherence. So if I'm going to battle with a person as to whether or not they're going to take a medicine, and I really want them to start on a platform therapy, and I encourage them, and I just can't get a person to commit to injections, then I'm not going to get my other 3 A's because they're not going to take the medication. So think about that. Have that discussion with your healthcare provider. So the oral medications, as we move up to oral medications, in some instances we do have superiority as far as proven that they are better than a previous injectable. Gilenya did a head-to-head trial with Avonex and proved it to be superior to Avonex. So in that head-to-head trial, I could say definitely Gilenya proved itself to be stronger than Avonex. So if I put a person on Gilenya and they're breaking through on Gilenya, would I consider going back? No, I've wiped out a whole class of medications. And you maybe look at me saying, you wiped out a whole class of medications? We have done head-to-head trials now with all of the injectable medications. Plegridy wasn't around, so I take that one off the table. But all of the other injectable medications in head-to-head trials, we have not been able to say that one is superior to the other. So in head-to-head trials, Copaxone held its own against beta-seron. It held its own against Rebif. So therefore, it would hold its own against the Stavia. It held its own against Avonex in the CombiRx trial. So if I put a person right out of the gate on Gilenya and they fail Gilenya, then would I go back potentially to one of these other therapies? I would have to be banking on that the mechanism of action is better, not that the efficacy, they're just a person that would respond better to the different mechanism of action. And right now we don't have a blood test to say this person is this kind of drug versus this kind of drug. It's just checking the report card and how they respond to that drug. Aubagio is another oral agent. Again, its mechanism of action is a little bit different. With Gilenya, we're sequestering lymphocytes in the lymph nodes. With Aubagio, it's working on overactive T cells and B cells. And so its mechanism is much different. It stays in the body a very long time. We can wash it out in 11 days with a rapid elimination if we need to. There's liver enzymes that need to be monitored with Aubagio. Tecfidera is a twice-a-day pill. It has proven itself to do very well. They did a head-to-head trial with Tecfidera and Copaxone. It was not powered enough for us to be able to say it has any superiority to Copaxone. So the FDA will not allow Biogen to market it as being better than Copaxone. It just wasn't powered that way. They did it because the Europeans wanted to see some data. So the Europeans don't allow for placebo-controlled trials. Here in the United States, we still do placebo-controlled trials. So in Europe, when they did this trial, they enrolled persons, either they went on Tecfidera or they went on Copaxone. So you may hear about this trial compared Tecfidera to Copaxone, but it was not powered to show superiority. So there's no superiority claim that can be made in a clinical research setting. Now, does that mean that your healthcare provider may not have a preference and may not tell you about something? But I'm talking about what is proven in research. Tecfidera works on your oxidative stress. You take it twice a day. And there are flushing side effects, GI side effects that can occur. And just like with the interferons, most of the time those problems are short-lived and go away within the first 3 months. And usually we can mitigate those with other medications to help with that if that's a problem. I think I may have neglected to tell you that there are side effects with Gilenya. Anything that we're sequestering your lymphocyte counts, potentially you could get infections, although we, didn't see any in post-marketing. We saw 2 deaths in the clinical trial, but we haven't seen any in post-marketing. There is the reduction of your heart rate, and so you have to be monitored for 6 hours. That can occur. And there is also a macular edema, and so eye checks before going on the drug and at 4 months. So every one of these drugs, when you talk to your healthcare provider, you need to be talking about what is the risk of going on the drug, what is the benefit, and then you make a decision based off of that. So infusions. Novantrone, I'm not going to spend any time talking about because I don't know of anyone in MS anymore that is using Novantrone. The heart cardiomyopathies and cancers that have developed with Novantrone over time. No one uses Novantrone anymore, but persons out in the audience may remember or may talk to someone who's ever been on Novantrone. So it was used in the past. It is the only drug that is approved for secondary progressive. So again, that may be something that in certain situations, you know, it's still up there, it still could be used, and that could be something that your healthcare provider would talk to you about, but anymore it's not something that is chosen because of the health risk of that. Tysabri is an IV infusion that you get once a month, every 28 days to be precise. The notorious thing with Tysabri is PML, which is progressive multifocal leukoencephalopathy, which is a brain infection that can occur because what Tysabri does is keeps any white blood cells from getting into your central nervous system, and that infection that you have already that your body is holding in check then can become alive in your central nervous system. Persons go on these drugs because they're looking for a better higher efficacy. So when you move up into these infusions, you're getting a higher efficacy. The safety profile is also a little bit different. So again, you know, it's knowing what you need and managing that with the risk. And so if you're not well managed, then that's something you should talk to your healthcare provider about. Lemtrada is the most recent that has come to market. This drug is not yet FDA approved for marketing to consumer. So you will not hear this from the drug company yet. The FDA says a drug has to be out on the market and be around for at least 6 months prior to a drug company being able to market to consumer. So this is a infusion that is a drug that wipes out your B cells. We know that B cells are important in your immune system. It completely destroys your B cells. You get 5 infusions, 1 every day for the first year. You're off for a year, and then you get 3 infusions the next year. We are, in our center, still doing extension trials, and so it's yet to be known, but right now the FDA has approved it for 2 years' worth of therapy. Because it is so powerful in wiping out your B cells, there is a side effect profile that comes along with this drug that's something that you need to have a discussion with your healthcare provider about. Again, we have seen reoccurrent other autoimmune diseases. Thyroid is the most common. In about 30% of individuals, they will develop a thyroid dysfunction. Sometimes it's temporary and goes away. Other times it requires permanent medications with thyroid medicines. There have been other autoimmune kidney diseases that can occur. There have been autoimmune blood diseases that can occur that can cause persons to have bleeding problems. There were malignancies that were reported in the clinical trial, but not higher than in general population. So the malignancy radar screen is pretty low for us. That being said, prior to going on this drug, persons are required to get a dermatology exam, and most of the time that can be done by your primary doctor, and a slew of blood works just to rule out any of these problems that we'd be looking for. The commitment, because I see persons' eyes when we talk about this drug light up. Oh, 5 infusions, 3 infusions the next year, off the whole year, off the whole next year. There is a lot of monitoring. So when you sign up for this drug, if you need this kind of efficacy, you are signing up for monthly monitoring. It is mandatory that you have blood work in the form of blood and urine tests done on a monthly basis. So again, the things that we see can be managed, but if we don't see them, there were persons in the clinical trial that had very bad outcomes. So it's a matter of catching these things early. So that's kind of all I'm going to say about disease-modifying therapies. You can get a lot of that from these drugs' websites. And all of these drugs are still doing patient programs. So I encourage you to go to patient programs to ask questions and to ask questions of your healthcare provider. Again, looking at your report card, looking at what your current drug is doing for you, how well is it keeping you on your report card, and then if your report card is not good, what risk are you willing to take? Again, keep in mind, part of your report card is your adherence to medication. So it's very easy for a person to be adherent to a medication that we infuse because we infuse it. But adherence means more than just getting the drug. Just like with the interferons, adherence means that you sign up to the blood work that needs to be done and eye exams or any other test that is required for that drug. So that's part of the adherence because it's all for your safety. We want to manage your disease, but we don't want to hurt you in another way. Okay, moving on to self-care. So I'm defining for you resilience. So self-care is all about building resilience. Resilience is having the right attitude, empowering yourself to be more than MS, to redefine yourself, and to have hope for a full life. So resilience is the capability of your body to recover its size and shape after some type of strain. Deformation caused by compressive stress or illness or some other problem. The ability to recover and adjust easily to misfortune or change. So what about MS threatens resilience? Well, it's a neurodegenerative disease. That's the hallmark of this condition. So it's characterized by relapses and disability. Often neuropsychological complications can arise related to inflammation and demyelination. Chronic neurodegenerative disease like MS threatens a person's autonomy, independence, dignity, and future plans. So that's potentially what a person, how MS is threatened, resilience. So what is the risk of low resilience? So when we look at neuropsychological features that point to a person may have low resistance, the most common are anxiety, depression, cognitive impairments, irritability, and anger. Less common, but can happen, is disinhibition, where persons lose their behavioral like their little gentleman that sits on their shoulder or female that sits on the shoulder and says, don't do that. Psychosis, very rarely can that happen, but it does sometimes. Apathy, which means you just don't care about anything. You're just, you're just there. Or behavior disturbances sometimes can occur in persons that have low resilience. So what are strategies for developing resilience? So we want to develop this so that we can better care for ourselves. Well, the number one is stay hopeful. You've been diagnosed with this, but it is not a death sentence. And even more now with 12 disease-modifying drugs, I am more hopeful for persons I diagnose now than I ever was in the past. So stay hopeful. Hope, we know in clinical studies, has correlated with quality of life. So if you're hopeful, if you're positive, your quality of life scores will be higher than someone who is not. Higher self-efficacy is also linked to hopefulness. So how much are you willing to manage for yourself versus having someone else manage for you? Staying involved in your care is also a form of self-efficacy. So one important thing for building resilience, especially with a chronic disease like MS, is developing a partnership with a provider. So again, I emphasize a partnership with a provider. You need to be with someone who respects you as an individual, someone who respects and accepts your right to choose, someone who considers your ethnic and cultural aspects, things that are important to you. someone who considers your health beliefs and your values, someone who respects confidentiality. You don't want them talking about you just anywhere. You want it to be you. And someone who focuses truly on your well-being, that cares about you and treats you like they would treat themselves or a member of their family. So that's what you should strive for, hopefully, in a healthcare provider. Now, that's not only a healthcare provider that's treating your neurology. You want to look for somebody like that who's treating all of your medical conditions. So your primary care doctor should be just as invested in your health as your neurology team. Your GYN should be just as invested in your health as your neurologist team and also your primary care. These individuals working together provide better care for you. And so fortunately in our practice we do have connections with most of the individuals, but it's not uncommon for me to get a call from a urologist, a gynecologist, and them to tell me something that they noticed on their exam that is not related to their organs. It's their organs acting out because of MS. And so they'll tell us that, and vice versa, I'll do the same thing. I'll tell patients, you know, look, this is the testing that I've done, but you need to follow up with your primary. And I've already communicated with your primary. And so it's having a team approach with all of your providers. And that goes for physical therapists, that goes for occupational therapists, that goes for counselors. So persons that will really work with you. So the other strategies for building resilience is self-awareness. If you are unaware of yourself and how you behave, it's hard for you to make changes about that. Being able to regulate how you behave and how you respond. Being optimistic, looking at the glass half full versus half empty. Having mental agility, so to be able to look at things from more than one perspective, to challenge yourself to say, well, I'm seeing it this way, but how are other people viewing this, and how would somebody else maybe see this? Looking at your character strengths and building on those, and then having a connection with other individuals. So specifically looking at character strengths, these are characteristics of a character strength. So looking at wisdom and knowledge in that domain, you're looking at curiosity, judgment, love of learning, and perspective. So you want to find something in these categories that you're strong in and emphasize that to build your resilience. Courage. Maybe you feel like you have no courage, but you know that you have honesty. So build on that to develop more bravery, more perseverance, and zest. Humility. Knowing that we are humans, we're loving individuals, we're kind to one another. Building on that, and if that's one of your greatest strengths, using that to help yourself, which then helps others, and helping others vice versa. Social intelligence, being aware of what's going on around you, being sensitive to others. Justice is teamwork, fairness, and leadership. Temperance is things like forgiving, humility, prudence, and self-regulation. And transcendence is having appreciation, gratitude, humor, and spirituality. So looking at these things and determining what of these things are you strong in, building on those, and as you improve your resilience in those areas, you'll find that then you can look at something in another area and build on that. So building little blocks will help you get bigger blocks. So focus on what you can do. You know, I try to encourage persons, you know, when they come in the office, you know, I'm always asking about, well, are you the same as you were the last time? I try to pull out the things that they can't do because that's what I need to know. But it's when I have a person come before me and I don't have to elicit that, and all they're talking about is, well, I can't do this, I can't do that, then I know I have someone who potentially has a lower resilience, and I need to work on with them. They've already told me all the things they can't do, so I have to remind them of the things that they can do or how they can reframe. With regard to medications, I tell persons that being on a disease-modifying therapy is being active in your MS. That is the best thing that you can do. You're taking a medication for you. It's not something that somebody is doing to you, whether you're injecting yourself, you're taking your own pill, somebody else is handing you the pill, somebody else is injecting you, infusing you, whatever. The medications are your active way of helping yourself. It's not that it's something being done to you. It's something that you are doing for you to attack your MS. Looking at MS as an opportunity versus a crisis. Have anyone ever heard when one door opens, when one window opens, another door closes, or something along? I'm sorry. There you go. Thank you. So again, all of us have things that happen that we have to change. And so looking at those, yes, when something happens, you're going to be impacted by that. You might feel angry, you might feel sad, but it's not wallowing in that. It's moving forward and saying, okay, now how can I use this to move forward? How can I use this to better enhance? Maybe I've needed to change the way I organize my closet. I've never had organization, but now because I'm energy fatigued, I need to do that. So it's the opportunity to look at things different. Maybe it is changing jobs. Maybe it is getting out. Maybe you've never been a social person, and now you have this disease that's potentially a very disabling disease, and it's better if you can get out and come to meetings like this or go to support groups and be with persons. So you challenge that aspect of the fact that you weren't outgoing, and you become more outgoing. Identify factors that are unpredictable and that you can't control. So if you know what those are, you're less likely to get caught off guard by those. So you don't put yourself in a situation where you need to be in control, but for one reason or another, it's not something that you can control. In other words, if spasticity is a problem for you, and you know that after I walk a mile, it's unpredictable how my last mile would go. So you don't want to be walking in the MS walks that are coming up without a support group of persons with you. If you're going to walk, you don't want to be walking alone. You want to walk with people that are going to be there to support you. If that's something that potentially could be unpredictable for you, you don't want to put yourself in a bad situation. The other thing is being active about the things that you can control. Your diet, exercising, sleeping, hydrating, getting support and being supportive, and your attitude. Attitude is really all we have that we can control, and it makes a huge difference. So looking at those things. So what are examples of resilience? When I talk about this and I've labeled all these things, what does it look like? Well, again, optimism and persevering. Persons that are optimists and persevere, that is a example of resilience. People who feel strong as a person, that's another example of resilience. Persons who are handling uncomfortable feelings, that is a huge act of resilience, being able to deal with it versus putting it aside and burying it. Thinking clearly and logically under pressure, that's another example of being resilient. Seeing humor in situations. I mean, I've tripped and near fallen before. I've, said words tonight that didn't make any, couldn't forget, but seeing how funny that is instead of being mortified by something like that, moving on, not letting it affect you. Didn't cripple and I didn't stop. I can't keep going on. Oh my gosh, you're all making me so nervous I can't speak, so I'm going to hide under here. No, you just move on. Knowing who and where you can get help from. This is not a go it alone thing. And whether you are married or not, whether you have a partner or not, there are people and friends that you have, and if you don't, then you should cultivate them so that you know who can be helpful to you, where they are, and have a plan for that when you need it. Generally feeling in control about your life. If every day you feel like you have no control of what happens, that is not a person who has resilience. So generally feeling like you have pretty good control. The tendency to bounce back from hardships and illnesses, that's a sign of resilience. Close, dependable relationships. Again, persons that have those are more likely to have a higher resilience. Over time, liking challenges because you know that you're capable of handling those. So you seek those out because you know that, and that then is affirmation of your body's resilience. Having a sense that things happen for a reason. You may not understand it when it's happening, but you'll understand it later, and having a positive attitude about that. We don't always understand things, but it's not always for us to understand. It's for us just to cope with and move on. Okay, so now we're going to move into your general health. Routine health screenings. So there are routine health screenings that every woman should get. Breast cancer, you should be doing self-exams every month. You should be getting mammograms yearly, at least starting at the age 40. Depending on your family history, you may get mammograms earlier than that. And again, depending on your family history, you may get BRCA testing, which is the blood test for looking at breast cancers. Cervical cancer screening, age 21 to 65, through pap smears, at least on an annual basis. Some insurance companies are saying every 3 years and up to the age of 30. But again, having that done on a regular basis, seeing your GYN, HPV screening at least every 5 years, and that should start at age 21 or the time that persons are sexually active minimally. Colon cancer checks annual from 50 to 75 years of age. Osteoporosis, if you're perfectly healthy, you haven't had a lot of steroids, 65 is what they say for general health. But persons with MS, I usually start encouraging them to have a discussion, and I ask their primary care to do that at age 40. And depending upon the use of steroids and Athgar, we may even do osteoporosis screening earlier, depending if they've ever had fractures or falls or whatnot. Hepatitis C should be done at least once. You should be screened to see if you have hepatitis C, and then repeat it if risk factors change where you might be at risk for hepatitis C. HIV testing should be done at least once in your life, and then repeat again as history indicates. So, if you are not in a monogamous relationship and you're, potentially at risk, then you should have this repeated. Lung cancer screening, again, depending on your history, but should start as early as 55 and should go on till at least we're 80. And so it's amazing that these things cut off but again, these are national standards. Most providers go off of history and will extend these either earlier or later depending upon your history. And we know that persons are living much longer, so I haven't yet known a primary doctor that has stopped screening persons at 80. Routine annual screening that should happen for everyone. So when you're going to your primary care doctor, you should annually be screened minimally for depression, diabetes, high blood pressure, high cholesterol, obesity, sexually transmitted diseases, and immunizations. Everybody can see this okay? Great, great. You should not be able to see this clearly. So if you're looking and you're saying, oh my gosh, I'm getting tired here, I'm fading, you should not be able to see this clearly. But this is a screenshot from the CDC's website as far as immunizations. What I want to point out is that with MS, you should be getting regular immunizations. There are only 3 immunizations that are considered higher risk and that you should really have a discussion with your healthcare provider. One is the varicella, the other is zoster, and the other is measles, mumps, and rubella. And so, we know recently that there have been outbreaks of measles seen in California. And so hopefully that persons have been adequately immunized. And so, but those are all live vaccines. Live vaccines put persons at risk of causing your immune system to be aggravated, heightened, and anything that heightens your immune system then starts attacking your central nervous system because, again, it's confused. It's not that it doesn't work, it's just confused. When it gets more heightened, more trying to develop antibodies for these live viruses, you could potentially have a relapse. So that's something that you should be discussing with your healthcare provider as to whether or not that you should get these vaccines. I encourage persons to talk to their healthcare providers about checking for antibodies. I can tell you that most of the time persons come into my office and they tell me I've never had chickenpox. Most of the time they have an antibody and they have been exposed to that. They may never have had the chickenpox, but they have an antibody. So we can test to see if you have an antibody to these things if we think that you're at risk. And so before you just go off and get a screening. The most common question I get around the fall is, can I get a flu vaccine? Can I get the Pneumovax? Yes. You can get shots. Those are not live viruses. If you get a flu nasal, that is a live virus, so you cannot get that. But shots you can get, and yes, you should, okay? Because you don't want to get sick. If you get sick, potentially you're revving up your immune system to fight off an infection. And when you rev up your immune system to fight off an infection, we know that relapses are more likely to occur following an infection. Nutrition. Okay, so we're going to talk about what is nutrition, what is a healthy diet, common myths, and research that's been done. So nutrition is nourishment. It's food required by organisms and cells to stay alive. It's the consumption and utilization of foods to maintain optimal health. So a healthy diet is not any of these low carbs, low calorie. It could be those things. It could be. But really, a healthy diet is a well-balanced diet. It's not how much you eat as much as the quality of what you eat. So the first and foremost about a healthy diet should be looking at the quality of the foods you eat. And then if you're consuming too many calories, that you strategically look at still providing that balance while cutting back calories. So variety, portionality, moderation, and the government has a wonderful mypyramid.gov, shows you all of the good foods that you should be eating. And so sometimes that means that you won't eat things that are not on that pyramid that add no quality to what you're eating if you're eating well and consuming enough calories. Most of the time, a chocolate cake doesn't do anything for us, but can you not have a chocolate cake and still have a healthy diet? Yes. Look at that. Common myths. Some people tell me, was it something I did that caused my MS? Was it a diet deficiency? Did I do that to myself? No. Can a diet cure MS? No. There's not a diet that can cure MS. There are diets that can make persons feel better. And especially in the remitting, relapsing phase of MS, if you feel better and you make a radical change and you feel better, you may think that that has cured your MS. But in fact, it hasn't. It has just helped you develop symptoms and maybe help you be more resilient. But It didn't cure your MS. There's no diet that will substitute for a disease-modifying therapy. Multivitamins are good for me. That's a common myth. Not all multivitamins. Unless you have deficiencies, you should not be supplementing with just willy-nilly vitamins. Supplements can't hurt you. That is the farthest thing from the truth. Supplements can hurt you. So you should be talking to your providers about these things. You should make sure that we know what you're taking. So what we do know is that vitamin D is extremely important. We recognize that more and more. It has not gotten to the level that we can say that it is a disease-modifying agent, but we know that it is helpful to our immune system in regulating our T cells. And so we know that persons are healthier with MS if they run a vitamin D level closer to 100. I keep my patients minimally between 60 and 100. And we know that it takes a lot sometimes for some people to get that level up there. And historically in MS, persons have lower vitamin D levels, even persons that have nice olive skin tones that we would think should not have vitamin D problems. But we're seeing it in all nationalities. And so it is a fat-soluble vitamin, so it should be a level that is checked on a routine basis if you're supplementing that. And if you're not supplementing it, should be checked on a routine basis to ensure that you don't need a supplementation. So that should be part of routine labs that are done through your provider. And if your provider, your primary care doctor, is the one that is testing that, please make sure that your primary care doctor and your neurology team are working together. Because what is good for us is not what a primary care doctor thinks is good. So I'm trying to keep persons between 60 and 100. And guess what? Closer to 100 is a panic value in most labs. And so somewhere around 75 in most labs, it comes up as a panic value. And your primary care doctor is going to say, whoa, wait a minute, stop taking that vitamin D. And so they need to have conversation with us, or you need to educate them. The other thing is insurance companies and pharmacists. When we prescribe these high doses of vitamin D, it is not uncommon. It happens to me 3 and 4 times a week. They call back and my MA said, yes, that's what she meant to prescribe. It was not an error in the machine. She meant for that person to take that 50,000 units every single day. We do load people with large doses if they're very deficient. Vitamin C. Vitamin C, no one should be supplementing vitamin C with MS. We know that vitamin C is an immune booster. We know it stimulates T cells and macrophages. Some people think it helps against urinary tract infections, but it really does not have enough evidence there that I would say supplement with vitamin C. Absolutely not. What you get in your diet should be plenty. Do not take vitamin C. So therefore, what's in a multivitamin? Plenty of vitamin C. Be very careful because some other supplements put vitamin C in there too. So be very careful. And B12 is one of them. Now, B complexes, you have to look a little harder to find a B complex that doesn't say B complex with C, because for some reason, somebody thought they should add C to it. So B12 deficiencies, we know, is a common cause of fatigue. It causes anemia. And it can cause all kinds of sensory symptoms. We also know that it can cause lesions in your central nervous system. It can cause lesions up in your brain. It can cause lesions in your spinal cord. So if you have a B12 deficiency, normal low is between 2 and 400. Below 200, and even in the low 200s, we're going to see all of these neurological effects. But somewhere between 2 and 400, even if you're not having white matter changes or anemia, you're probably going to be fatigued. So I tell persons to go ahead and supplement B12 if their B12 level is low. Now B12, pure B12, unless you have a rare blood disorder, is not harmful to anyone. You just have to be careful that you're using straight B12, because B6, which is in a B complex, can be harmful and can cause neuropathy. So if you want to supplement and not have it tested, it is a water-soluble vitamin, so make sure you're just taking the straight B12. Omega-3 polyunsaturated fatty acids, we know that there has been some research that shows that this may have some mild immunosuppressive type of effects. The problem is that this is such a dirty drug, and there's not been not enough literature that typically I don't ask persons to take omega-3s. It causes problems with diabetes, bleeding problems. There's a lot of other medications that it interferes with. So the only persons that I have that are taking omega-3s is monitored and prescribed by a cardiologist. Okay. Enzyme CoQ10 has an immune stimulating effect, so that's just like vitamin C. I tell persons don't do that. And at higher doses, the higher doses that potentially would affect Parkinson's disease, they can interfere with your liver and have liver toxicities, and can also interfere with other medications. So I don't recommend persons go on enzyme CoQ10 for MS. Caffeine. I put this in here not as a supplement, but I put this in here as, again, diet. We know that persons routinely use caffeine to help with fatigue management. It can help with mental alertness. I caution persons, when you're drinking your caffeine, guess what? It's not going to have effect for those things until 30 to 45 minutes after you drink it. So if you're going in for an interview or something that you really need to be alert, you better have that coffee 45 minutes or so before that event is going to happen. But then guess what happens at 45 minutes after you have coffee? Got to go to the bathroom. And so if you need to be alert and you have to sit still, caffeine might not be the drug you want to use. Now, again, persons who have been drinking caffeine on a regular basis, some people don't have that dramatic urinary issues, and some people don't have it all, but it is known bladder irritant. So be careful that it's also a diuretic, so even if it's not irritating your bladder, it can cause you to have to pee more. And it also increases your risk of osteoporosis. So again, use caffeine wisely. Alcohol. Alcohol is a sedative to the brain. And so if you are consuming alcohol, anything you want to do that's not necessarily healthy, you always want to do in moderation. But you need to be careful if you're sedating your brain and your brain already has some issues. So if you go out for a night and you're drinking some alcohol and you typically have a little bit of a gait problem, guess what? That gait problem is going to be much, much worse, and you'll be high risk for falling. If you're already fatigued and tired, guess what? When you drink, you're going to get even more fatigued and tired, and you might fall asleep at the table. But you know what? It has this really weird thing. As it sedates you, as fast as it sedates you, about 4 to 6 hours later, it leaves. And so persons who fall asleep drunk or intoxicated, in the middle of the night, boom, their reticular activating system is suddenly aroused because the alcohol leaves, and it can cause for a very irritating night. You don't sleep through the night, so that can happen to you too. It increases the risk of mood disorders and anxiety, and also is higher associated with suicide in MS. So again, be knowledgeable about what you do, your fall risk. Falling is never good at any age. Please don't fall. And it also can worsen bladder dysfunction, and it also has some diuretic effect, and it adds calories. So just careful. All right, intimacy and sex. Sexuality is more than sexual function. It's an ever-changing lived experience, is always affected by the manner in which we view ourselves, our bodies, with constantly changing social and cultural influences. Okay, so that's how you define sexuality. What does intimacy mean? All of these labels up here are included when we talk about intimacy. So intimacy is the act of sex. It is love. It is caring and being cared for. it's sensuality, relating, it is intercourse, empathy, protecting. Conversation is a huge, that's why it's so bold there. Conversation is essential for intimacy, touching, looking, honesty, body language, to want, to understand, commitment, and to accept. These are all things that are part of intimacy. What is sexual dysfunction in MS? Well, it can take several forms. One is desire. The lack of desire, I'm not interested at all. The other could be an arousal problem where your body does not feel the response to sexual stimulation that you used to. Or it can be the opposite. You can't keep up with your body. There are persons that have sensory problems. You may know them in other areas of your body where something that should feel good doesn't feel good, or something that should feel one way doesn't. And you can have the same in your sexual organs where either you don't feel them very well, or it doesn't take much. You can be sitting there and all of a sudden, ooh. It can go either way. Orgasm, you could maybe not be able to reach an orgasm. And there is pain that sometimes can be associated with sex in MS. The good news, and I always like to put this up here for persons, is sexual dysfunction is very, very common. So this should not be something that you are afraid to talk to your healthcare provider about. And I'm sad to say that many of my colleagues find this as uncomfortable to talk about as you may have uncomfortable to talk with us about. So when they did studies asking healthcare providers on NARCOMs, how many times do you ask your patients about sexual function? Very, very few times. So maybe never. But it occurs frequently in all disease states. So you don't have to just talk to your neurology team about it. You can talk to your primary care team about it. It's very common in vascular diseases, diabetes, heart disease, lung disease, all of these things. MS is up there. But the other thing to consider, sexual dysfunction can be a product of what you are doing. So alcohol use or drug abuse, medications and the side effects of medications. So those things can create a problem for you. So again, have that conversation. So there in MS specifically, we're looking at two different types of sexual dysfunction. One is a primary sexual dysfunction and the other is secondary. So primary refers to lesions that are causing the problem. And the problems that you can have related to primary MS problems would be decreased or absence libido. So either you don't want very often, no desire, or you can't remember the last time you desired. Altered genital sensations, decreased frequency or intensity of orgasms, erectile dysfunction, decreased vaginal lubrication or clitoral engorgement, and decreased vaginal muscle tone. So all of those things can be from the lesions that you have. Now again, they can be part of other problems as women age. Menopause is common for causing persons to have vaginal muscle tone changes and to have lubrication problems. So again, you need to share these both with your neurology team and with your gynecology team. Secondary symptoms, bowel and bladder dysfunction. That can cause problems in the bedroom or the kitchen or wherever. Fatigue. Non-genital paresthesias, pains, spasticity, decreased non-genital muscle tone, so decreased tone in other areas, cognitive impairments, tremor, and pain. So the key is, what the problem is where you go for the solution. If spasticity is a problem, you're going to want to talk to us about getting on the right medication or timing your medications around the time that you are going to be engaging in sex. The other is looking at things that can support you. If you've got weak muscles and you can't hold your legs up, well, then you might need to change the position, or you might need pillows, different things. So there are ways to get around these type of things. So medical management of sexual dysfunction in women. Believe it or not, we do give things like Viagra, and it has been helpful to women. There is another drug that still has a number, PT-141, that is in phase 1 trials, looking at increasing sex drive in women. Right now in rats, it's doing pretty good, so we'll see. There are other medications that we use. Phenytoin and carbazamine can help with women. There are a number of other things that you can get, things that we can prescribe through your medical insurance would pay for. So a clitoral vacuum pump is something that we can prescribe and your insurance will pay for. Vibrators, sexual aids, those are good things. Water-soluble lubricants, Kegel exercises, body mapping, and we're going to talk about that in a little bit, and placing more emphasis on intimacy and communication. Maybe when we were young, 18, 19, 20, we could just go in and get it done, and it was great. But you know what? As we age, you might need a little more foreplay, might need things a little bit different, and so those should be things that you should be looking at. Be open to looking at some of these sexual aids and vibrators and different things that might help you. So body mapping is one of the things that I encourage persons to do. And so this is exploring your body. You can either do it independently or you can do it with a partner. So the very first thing is you want to be in a safe, comfortable place. You want the temperature to be just right. You're going to take off all your clothing. And you're going to begin touching. So let's say you're doing it with a partner. You're going to touch from head to toe and everywhere in between in a very systematic way. So you're getting to learn, well, what does it feel like when you touch me here? What does it feel like when you touch me there? And you can either write it down, you can have a little video recorder, whatever, so that you remember those things. And so when you're moving down, you should be varying pressure, speed, and pattern. Because maybe touching me right here does nothing when you just rub me like this. But maybe if you did it really hard, it might make me feel a little bit different. So it's exploring those type of things. Note areas that are pleasurable and note areas that are not pleasurable. So you want to find that out before you're trying to engage in a meaningful experience. You know, alter touch to maximize pleasure. During this experience, you should not, the goal here is not to fulfill yourself. It is not to go about the act. This is not foreplay. This is an experiment. This is an experiment where you're getting to know yourself. And so your goal is not to obtain an orgasm. Your goal is to figure out where are your hot spots. And where are your cold spots so that you can avoid them? Communicating with your partner all through this is extremely important. So managing an attention and concentration problems, because that can be a problem for individuals. So making sure you're in an environment that is saturated enough to keep you in that moment with minimal distractions. So maybe you need to close the door, put the blinds down, turn off the music. Maybe you need music. Create re-entry rituals. So again, this requires communication with your partner. So if you have a problem with staying focused while you're in the act, you should be able to identify that and then on cue, give your partner a cue that, hey, I'm losing it. And so then that goes back to the body mapping. So something that was very pleasurable for me, that felt really good, Well, we may need to stop and go back to something that really caught my attention and brought me back into the moment. Addressing interfering thoughts and interruptions. So you don't want to go into doing this when the kids are all running around, when your house is a mess and you're worried about the fact that the in-laws are coming over or whatever. You want to go into this with as much as you can peace and being able to separate yourself from that, other things. So again, learning how to alter the pace of sexual touching, communication, and when distractions occur. So having that plan for when that happens. So how do you talk about sex? Well, the first thing is, most of the time, it's better if you have agreed upon ahead of time when and where it's comfortable to talk about this. And so what sometimes happens is persons don't talk about it, and kaboom, you have a whole bunch of friends over and it gets a little lively, and then you splurt out something like, well, I never feel good in bed anymore, or I don't care if we ever fool around anymore. And then kaboom, you've exposed that to a whole bunch of persons and really didn't mean to. So agree upon when and where that it is comfortable to talk about those things. Use books, handouts, videos to talk about, to help with discussion. Don't criticize your partner or blame them. Use things like, well, I feel, I would like, not you don't. You don't feel this. You don't know how I feel. Your legs don't. So try to just express yourself in a positive way. Expect that when you're communicating and you're asking for things, that there may be some things that get turned down. I mean, you may want to try something, and that may not be something that your partner wants to try. And so, again, it's negotiating. But when you get to that part, if you're ever turned down for something, recognize, and it should be agreed upon, that the person is not turning you down, they're turning down that particular part. And so replace that with, find out about what that was that you wanted that was stimulating or good for you, and see if you can try that in another way. Be aware of your sexual feelings and preferences, and be aware that at MS that can fluctuate from time to time, so being a little bit lenient on yourself. Using nonverbal communication for your partner. You could be feeling really good and you want to go home tonight and do it. So instead of, you might just bring their hand over and rub them a little bit. Same thing, if you're in the act and they haven't hit the hot spot that you guys identified, help them out a little. Don't expect your partner to know everything. It's your body. You should know it better than anyone else. And so expect that. Part of the gratification is that you're in control and you help that person learn about you and fulfill you. And likewise, your partner should be helping you do the same for them. Because part of a healthy interaction is that both persons are satisfied. So this should always be a two-way street. It shouldn't all be your way or all their way, but both persons should be satisfied. And so don't, again, expect perfection. Recommended books. There are some really good books on the topic. And so here they're listed: Resurrecting Sex and Hot Monogamy. So check out those books. All right, relationships. Now I just got the heads up, about I'm supposed to be quick here. To disclose or not disclose. That is a question that is from the dawn of time that persons ask me that question. And it varies from individual to individual, and you need to think about that. You need to make sure that you have weighed the consequences before you take that leap. So in dating, when do you tell somebody that you've got MS? Well, Think about anything else about you. MS is just a part of you. It does not have to be the first thing you say to someone when you meet them. Hey, my name is Patricia, and I have MS. That does not, it doesn't have to be the second or third thing. You don't have to tell them until you're sure that there's somebody that you want to be with for a period of time, because they don't need to know that. They don't need to know whether you're a diabetic. They don't need to know whether you have heart disease in your family. They don't need to know any of those things until you're comfortable either that they're going to be somebody that stays in your life or it's somebody that you feel you want to share with. At work, it's a whole nother thing. At work, you really need to be careful and make sure that when you talk, that you are okay with that being out. And I can't tell you the number of individuals that tell me, well, I have a friend at work, and I shared it with my friend, but, I really didn't want everybody else to know. And you know what? The only persons that are bound to HIPAA are your healthcare providers. Your friends are not bound to that. And your friends may want to be helpful, and they may not see that they share something about you as not being helpful. So just be very careful about at work if you're going to share. In certain companies, it's very advantageous to tell persons that you have MS, because in bigger companies, there's a lot more structure. There's a lot more. The family medical leave has to be abided to in different things. If your work is in a good situation, you're a good performing employee, you may be much less scared sharing that than if you're a person who's having problems at work. If you're having problems at work and those are related to your MS, you might want to try working them out outside of work with your healthcare providers before you share at work that it is. But keep your healthcare providers in the loop. So that if there's a problem, we can help. But, again, just be careful how you show. You should always want to know, again, what your outcome is in telling persons. Always be positive. What do you want a person to know about you? What do you want them to understand about you? What's the best way to deliver that information? If you're going to tell somebody about this, you want to make sure you tell them in the right environment, and recognize that most persons, when you say MS, they have no clue what that is. So it has to come along with a long education, because persons will make assumptions that are not accurate. And what kind of response do you expect? And be expecting to get the unexpected, and be prepared to deal with that. So talking about parenting and impacting the family, please know that your MS affects you, and it also affects every other member of your family. We're first going to just real quickly run through pregnancy. I just want to tell you, if you're of childbearing years, MS does not do anything to alter your ability to get pregnant. Please, none of the disease-modifying therapies are approved for pregnancy. Copaxone gets the safest category. It's a B, and so some persons will leave Copaxone on while they're pregnant, but all other ones are in question. And so it really needs to be a discussion that you have with your healthcare provider, risk benefit. You should be using birth control and discussing that. All of the drugs have pregnancy registries, so if you get pregnant on a drug, please make sure that you notify the drug company and get put on their pregnancy registry. So dynamics at the time of diagnosis. Family response is unpredictable. Know that. The adjustment period will differ from family to family, and it depends on, well, what were your family dynamics before you got diagnosed with MS? If you had a very intact, very loving, very supportive family, then you're going to probably fare better than someone who is one step away from signing the divorce paper, and you find out that you've got MS. That's probably going to be a whole different conversation. How able are you in your family prior to your diagnosis to share and communicate openly and effectively? That's going to be challenged in the best situation. So if you didn't have that before going in, expect that that might be an area that you need to work on. What was your financial status? Initially at diagnosis, that's what most people worry about. Am I going to become disabled? What's my outlook going to be for the future? So if your financial status is a little shaky, that might be something that affects how persons initially respond. Persons may be shaken. It may be life-altering. I say maybe because I've seen some people that don't appear very altered. I think it is life-altering for everyone, but it just depends on how. But it can be something that helps persons grow closer. So look at, again, the opportunity for closeness versus the opportunity that this is going to automatically separate you. And if taken on appropriately, most of the time it doesn't result in that. But there have been several studies that say the divorce rate in MS is higher, but so with any chronic disease state. So it's not just MS, any chronic disease state. So what can enhance coping? Well, the number one thing is education, because just like when you're first diagnosed and as you move along with MS, it's all in education. The more you educate, the more you know, the better you'll be able to cope. Sharing feelings and struggles, that's extremely important. Setting realistic goals and expectations. If when you are first diagnosed, you're having difficulty walking, or not something maybe as dramatic as that. Let's just say it's a visual problem. Nobody can see that but you. Well, you may need to alter what you're doing and be realistic that that might need to be altered for a period of time, not expect that, well, I'm going to continue doing everything just as before. Seek outside help, support groups, clergy, professional counseling. Get physical help if needed. Get help, period. If you need help, get it. Even if you don't need help, learn how to take help. Explore financial resources. Find new activities. Find things that you can do to enhance your experience with your family and your time together. And reassure family members that they're important to you. And they should hopefully be giving you the same, that you're important to them. Roles in families nowadays are very dynamic. Very changed. Some people still have very traditional families. Some don't. You may need to adjust your role in the family intermittently, and so there should be a constant negotiation of what are the tasks that need to be done and how does it get done in your family. Again, communication is extremely important for this. You want to identify problems, identify solutions, identify them in a way that you are expressing your concerns about the situation. It's not that you're inadequate or this other person is more or isn't, identify really the root of the problem so you're taking out personal feelings and trying to be productive in developing solutions. Look at the pros and cons. So if, you can't anymore go take the children to school in the morning, well, what alternative can I get for that? Can I get the neighbor? And what would be the pros and cons of that? If I'm getting help, what can I give? Again, seeking resources and negotiating. And the whole goal is for a win-win situation, that both parties are winning and everybody is getting their needs met. So children's responses, these are common responses that children will have when their parents talk about MS. So expect anger, fear, embarrassment, guilt, sadness, resentment, depression, and hopelessness. Helplessness. The behavioral response from that. Persons may be increased about their own body well-being. They may have difficulty forming close relationships, higher anxiety and stress, false sense of needing to grow up too quickly, behaving bad in public, lying to their friends about their parents' illnesses, regressive behavior, acting much younger than they were, again, having temper tantrums. They may struggle with what can you do and what can't you do, so you may find that all of a sudden they're asking you to do things when is later than you would typically be doing, and you need to address that and set expectations. Poor performance at school, nightmares, bedwetting, and trouble falling asleep. These are all common things that can occur. The issue is, when do you need to get professional help? The key to dealing with children, again, is the same with the adults. Education, being positive. The MS Society has lots of programs for helping with children, so does the association and the foundation. When it's important for you to recognize that you might need to get help is when there's depression, when there's severe or chronic behavior problems. If any one of those things I listed back here occur once or twice, that's just okay. That's just part of what, they're moving through, coping, learning to cope. But if it becomes a chronic behavioral problem, that's when you might need to seek help. If they're having difficulty with sleeping, nightmares that are happening consistently over a month or more, then that's time. Either increased appetite or decreased appetite. They're losing interest in schoolwork, extracurricular activities, or having mood swings, personality changes. These things, then you might want to involve a professional to help with that. So, questions that children commonly ask. If you have MS, does that mean I'm going to get it? Everybody know the answer to that question? Okay, it doesn't mean that they're going to get it. Direct twins, there's only a 20% chance in direct twins. So you can't say categorically, no, you're not going to get it, but there's a very low chance that you're going to get it. So don't answer ever like with anything with a child. Don't give them more than what they ask for. Don't you need to go into a long dissertation? Well, not likely, but it could happen. Will your symptoms get worse? We said this is a chronic degenerative disease. Again, depending upon your child, you're not going to start with, oh, well, it's relapses and I'm eventually going to get worse and worse and worse and worse and worse. And, that may happen. It may never happen before you die nowadays. But it may happen so gradually they don't experience it. So will I get worse? Well, I may. And it may take years for me to change it all. You may not even notice that I get worse, but I may, and I may need your help sometimes. Why is there not a cure? Everybody wants to know that. You want to know that. Well, we don't know that. But persons are looking forward to that, and there's hope for that, and we're doing a lot more research, so you want to emphasize the positive to your children. Are you going to die? MS does not kill persons. So you want to share with your children that no, this is not going to kill me. This may change me. I may need your help sometimes, but I'm not going to die of this. So you want to share that positive message with your family. I want to end with a few last things. The happiness advantage. Happiness gives your brain the competitive edge. It's a misconception that success breeds happiness. If that was true, if all persons that were successful, we would not see millionaires, we would not see basketball players, football players getting into trouble. Because we say that they're successful, those of us, So success does not breed happiness. Happiness is a choice. Waiting for happy things to happen, waiting to be happy will limit your success. So make yourself happy now and you'll actually be more successful. There's no single meaning of happiness. Happiness is relative to the person and what they experience. Based on how you feel about your own life is whether or not you're going to be happy. So I encourage persons to look for those happy things. Again, the MS Society has a whole clip on this that's really good. There's a lot of things that in the research now in becoming happier. One of the things that Biogen has done to help persons become happier is this MS Blueprint. You can find it on www.msblueprint.com. It is a tool that you can use to define for you in your life things that will help make you have more enjoyment. You pick and choose and go through and you develop a blueprint for your success based off of what you want in life. So I challenge you to go out there, to look at the MS Blueprint, and to attain happiness. Happiness builds resilience. Happy persons take care of themselves. Happy persons take care of their MS and are much more successful. Thank you all.
So we're going to do this Q&A. You don't have to turn around. Nobody turn around, okay? It doesn't matter. I'm going to be leaving the room. Bill's going to be leaving the room. And we're going to ask whatever gentlemen are in this room to please vacate the room. I don't know how we're going to know to come back, so somebody's going to have to yell or something, or send me a text message. Or maybe I'll go to the bar. I have no idea. So listen, ladies, enjoy this Q&A. It's something probably that you hopefully never had before, and it's a first, but I don't know. And, just go with the flow, so to speak.
Anybody with a question? Ladies? Well, no. Shoot.
Okay. First question. Shoot.
I wanted to know more about resveratrol in red wine. Is it good for us?
She wants to know more about resveratrol and red wine that's not good for us.
Is it good for us or not?
Oh, is red wine?
It's good, but you're telling us not to take CoQ10 and vitamin C, so I'm just curious about the red wine.
Well, red wine will decrease your platelets, and if you're taking aspirin for another reason, then red wine may actually contribute to your heart disease and strokes. But if you're not taking aspirin and you're normal, healthy, one glass of red wine a day has not been statistically significant in altering a person's health. Again, if you're not an alcohol consumer, you just have to weigh that with what your level of disability is, because that one glass of wine is going to affect you differently if you're not an alcohol consumer. And I encourage persons to think about, even if you are an alcohol consumer and you're used to drinking that one glass of red wine every day, your brain gets a little bit more accustomed to that, but it's still sedated while you have that. And so be careful about what you need to do after you have that one glass of wine. I'm sorry, I need to go back in front of the camera.
I have a question. You talked about when to disclose or not to disclose. I'm curious about the people in this room, and if anybody is willing to speak about it. I have MS. I'm in a scooter. It's kind of hard to hide the fact that there's something wrong with me. But if I were to go on an online dating site, do I write about the fact that I have MS or that I'm significantly disabled? Some people can walk into the room and have cognitive issues, and they don't have to disclose it. But how do other people handle the issue of meeting people and dating people?
I can answer that. Oh, I can speak loud enough.
No. We need to talk on the microphone.
Okay, first of all, I don't think you should disclose until you get to know the individual. Then you can disclose. I disclosed personally to the fiance that I have now because he was okay with it. But if it had probably been somebody else, not as understanding, I wouldn't have, until I got to know the person a little more and gotten to know their stand on it.
Anybody else has a comment?
I want to make just one comment about something that you said. So the invisible symptoms of multiple sclerosis. You mentioned cognitive impairment. I've had patients that sat before me and tell me, I'm not cognitively impaired. And we'll go through an interview, just a routine interview, about asking about this, asking about that. I don't know. And I will point out to them, you told me you're not cognitively impaired. You may think that's invisible and not as visible as your scooter, but those of us who are not cognitively impaired, we see that in individuals. And so we're questioning, why is this person who looks so, quote, good, not able to think clearly? What is wrong with this person?
We have another comment back here.
Okay, I want to comment. You were saying when to disclose and when not to disclose. I recently met a person, and I did share with him. I did not meet him online, and he asked me the first date that we went on. He did not ask me, and you all see I walk with a cane, so mine is visible. a person that doesn't walk with a cane or have a wheelchair, that's the first question a person's going to ask. What's wrong with you? Did you have an accident? Did you have surgery? So then, you know, should we disclose? I personally say you should wait till you get to know the person a little better, if you feel comfortable, if it's going to be a meaningful relationship. But if that person asks you, and then, you know, you decide. In my case, my friend, he asked me, I think it was a 4th or 5th date that we went on. The first time he did not, because most people do say, what's wrong with you? Did you have an accident? Did you have surgery? And I'll just say yes. And I don't disclose in it, I just say yes. But on the 4th or 5th date, he did ask. He asked, what happened? Did I have surgery or did I have an accident? And I started to lie to the person. I thought, should I lie to him or should I tell him the truth? And when we did talk, he did say he wanted honesty in the relationship. That was very important to him. He wanted to communicate. He wanted to have respect. So I decided, what should I do? I told the truth. I did share with him that I had MS. And he said, okay. And I looked like I was shocked. And I said, do you know what MS is? And he did. And we went on a walk. And he expressed to me, he said, you know what? He said, don't worry, because I told him, I said, I have MS. MS doesn't have me. It's an attitude. You have to have a good attitude about MS. And he shared with me, he said, don't worry. He said, we're going to get through this together. We're going to fight MS. You're going to beat MS. He eats very healthy. He exercises. He doesn't smoke. He doesn't drink. And that's truly a blessing. And he told me, he said that I am going to teach you how to eat healthy. I'm going to help you deal with your MS. And I was like, oh my goodness, this have to be from God, you know, because that's not a normal reaction for a person to respond that way. Most of the time, a person, they're going to be fearful. They're going to be afraid. MS, is that a death sentence? Is that contagious? What is it? You know, I don't want to deal with it because they're afraid of you being dependent on that person. And I was just blessed that he didn't feel that way. So I just, you know, thank God that he did respond in a positive way. And, you know, to each his own. But I was blessed to meet a decent person. And we're, you know, taking it, you know, one day at a time. And he is very supportive of me, so I do appreciate that. So I just want to let other people know that there are good people out there, but you have to use common sense. You have to know when to disclose and when not to disclose. So if you do feel comfortable, then you disclose. But if you don't feel comfortable, you don't disclose. And I would suggest don't, you know, really say anything in the beginning, because sometimes it will frighten them. It will scare the person away. So, again, each his own.
Thank you.
The only concern I would have about an online site, and again, you have to be careful. You don't want to make yourself, on an online site, you don't want to make yourself vulnerable to those individuals who may seek you out because of a disability as a person who might be vulnerable. So, you know, just again, know what you're expecting before you disclose and what you want out of that, and keep that in mind.
Isn't there a site for disabled individuals to meet other individuals? I thought there was.
Well, there's a site for farmers to meet farmers. There's a site for my time over 50s. I'm sure there's a site for disabled persons to meet other disabled. I'm sure there is, but I don't know.
Any other questions?
There's a question from...
Oh, interesting. We have one of the hostess at the hotel. She has a question. Hey, good girl.
What are some of the symptoms of having MS? Because I really haven't studied upon it, and I haven't been able to see a doctor, but I do have chronic back pains, and it goes all the way down to my legs. So I'm kind of wondering if I actually get to go see a doctor in March, so I'm kind of
Yay.
wondering what some of the symptoms of having that, and what's the earliest you find out that you have MS?
Very good question. So the symptoms of MS really could be just about anything, because your brain is the controlling system of your whole body. And so pain in your back that radiates down your leg, the very first thing I think of is not MS. I think of a pinched nerve in your back. If you were to describe the whole half of your body or both legs having sensory problems or weakness, then I would be more concerned about MS. So I think that initially my first gut reaction is you probably don't have MS. And MS is a very rare disease, and so much more common to have pinched nerves in your back than it is to have MS. But symptoms of MS could be visual symptoms. We've talked about cognitive problems, sensory symptoms, weakness, bowel, bladder problems, vertigo, inability to walk straight, ataxia, those type of symptoms.
We have a question in the back. Yes, in the back.
The First Lady mentioned resveratrol. What about a high-quality supplement, resveratrol? What are your thoughts on that?
You know, I don't know the content of what's in a high-quality resveratrol, so I'd have to look that up and get back.
We have a question this way.
Just so she knows, if you don't want to take the pill, Walmart does sell resveratrol, like in cognitive delay, in a juice form, kind of natural thing. Because Dr. Oz had mentioned it, and I went looking for it, and I found it with resveratrol and acai. Mm-hmm.
So on that bottle, what does it tell you that resveratrol is going to do for you?
I don't know. I can't remember that. You asking me?
It's equivalent.
We have MS.
I take it. I don't take a liquid, but but Andrew Lessman, who has really high quality vitamins, and I forget how many glasses of wine it's equivalent to, but I'm going to say more than 40 glasses of wine, one capsule. And so I take it daily, but I have to confess I do not have MS. My sister does, and I'm here with her. I just wanted your opinion on resveratrol.
So the components of red wine that are good for us, if they can put that just in that supplement, that's great. But if that in any way enhances your immune system?
I think it's to help boost it. It's for youth, vitality. I can't remember
And so
everything.
right there, I would say that is against. So
yeah.
Anything that boosts, enhances vitality, those things are causing your immune system to be more aggravated, elevated, heightened, however you want to say. Persons with multiple sclerosis do not have a bad army. Your immune system is your army in your body fighting off things and whatnot. You don't have a bad army. Your army's just confused. All your soldiers are there. They just don't know who to follow. They're going in and attacking your central nervous system. So if you add more soldiers or enhance those soldiers' ability to do their job, they're confused. Their job, they think, is to attack your central nervous system. So if you get more players or you help those players be stronger, that potentially is going to impact your immune system, because every drug that we use is to modulate or suppress the immune system.
Thank you.
So we don't need nothing to boost it up.
You need nothing to do anything. Nothing. None.
Have you come across any patients that have MS but show no lesions in their spine or their brain?
Is it possible to have a person who has MS that has no lesions in their spine or their brain? Now, I have a few patients who have MS who have no visible lesions in their brain. I don't have any patients nor do I know of any patient who has not had any lesion anywhere in their central nervous system at one time or another. So again, remember, lesions have the ability to come, go, get bigger, turn into black holes. So at some point, a person, my patients that have no lesions in their brain, they were able to articulate or I examined them during the time and can map back to an area of their brain that caused their symptom, their relapse. The MRI didn't show it. We know MRIs don't show everything in MS. There's gray matter disease that we don't see. Things that are degenerative, we don't see as much as inflammation. So there's disease there. We just can't see it on the MRI. So the necessity, if you don't see it, is a good history and an examination to prove that it was there. We just can't see it. We know in doing studies where we've done biopsies on individuals, in MRI areas that look perfectly normal, we take out cells. We know that there's demyelination that's occurring there, so it's possible. But at some point in time, a person had to have some type of alteration in their central nervous system. So to see a person that has nothing in all three areas, brain, cervical, and thoracic spine, is very highly unlikely. It's not, can't ever happen, but it would be exceptionally rare.
Is that another reason why they do the lumbar tap?
Right,
spine?
So spinal taps are used to exclude mimics of MS, but also in persons that have lesions that don't really look classic for MS, but they've had symptoms of MS and relapse type symptoms, and then we can look at cerebral spinal fluid and look for those oligoclonal bands that should not be in the cerebral spinal fluid higher than they are in serum. So comparing the two of those, so that does help us in individuals. So diagnosing a person that doesn't have lesions is a very, very hard thing to do, not impossible.
Okay, we have a question here.
You mentioned the OG bands, the oligoclonal bands. Is there a, I guess like a system, a number system? I was diagnosed with that I have 17 bands. I don't know what that means. Is there a range?
Excellent question, and that comes up frequently. It's OCBs, oligoclonal bands, and there is a range. You get a number, and the number really beyond saying that it's positive, we have not been able to demonstrate in a good fashion that it means anything. So a number of 5 versus 17 is not prognostically significant for us. So I can't say a person that has 17 is going to have a much worse course of MS than a person who only had 5. So it's either you have, really to be considered positive, you have to have 3 or more. 3 is really kind of on the borderline, but 4 or more oligoclonal bands, and at that point, it's MS. And so whether or not you had 4 versus 17 doesn't tell me anything about what you're going to be like.
Any other questions?
I believe you mentioned there were 3 vaccinations that those of us with MS should look to being receiving, and I caught MMR, but I didn't catch the other 2.
Okay, so the 3 vaccines that you should not be getting, not get, unless directly counseled to do so with your neurologist, are the live vaccines. So varicella, zoster, and the MMR, measles, mumps, and rubella, those are live vaccines. So those would put you at higher risk for having a relapse after you take a vaccine that is live and is going to cause your immune system to become more active. Now, there are certain situations where you have to do that. We're told if we put persons on Gilenya and they have not had immunity to chickenpox, that we should vaccinate them. And you know what? As much as I hate doing that, I do it because you know what? If I don't, and that person is a person who comes out later to get herpes encephalitis, their family's going to come back to me and say, why did you not vaccinate her before you put her on a drug that has, in clinical trials, had persons die of herpes encephalitis? So again, it's a risk benefit. If the drug that you're going to go on has such a high risk and you don't have immunity, or you're going to be exposed, then you would potentially need to get that. The other way is sometimes, like with Lemtrada, there is a high incidence because during the period of time that you have no B cells, that you could get a shingles outbreak. And so even if you've had exposure to shingles or chickenpox, so you shouldn't get it, but the incidence is so high because your immunity is so low that we prophylactically treat persons. Now, I have had some persons in the community of MS who have chosen not to vaccinate on a drug like Gilenya, and they just go ahead and prophylactically treat them for as long as they're on Gilenya. So again, it's a discussion that you should have with your healthcare provider. But those 3 vaccines were ones that you should not get.
Any other questions? Oh.
Oh.
I know, I'm telling her to head to the back for after yours.
Mm-hmm. Can we clarify the significance of bee stings for people with MS?
There's no significance in bee stings. Bee stings, that was a fad that went around back in the early 90s, and I still hear it come up here and again. But again, the thought was that you would get these bee stings and your body would develop a resistance to this, and it was like giving yourself an allergy shot by bee stings, and that resistance would then translate to not having MS attacks, and it doesn't work. So a lot of pain, a lot of welts, itching problems, and then you still get MS relapses.
We have a question in the back.
How come my neurologist told me to absolutely not get the flu shot?
Maybe there is something about you personally that your neurologist knows that I don't know, but maybe your neurologist is not aware that you could get a attenuated flu vaccine, meaning it's not a live vaccine. Maybe your other health problems are such that she feels that you are higher risk of getting the flu if you take the flu vaccine. But a lot of people who choose not to take the flu vaccine listen to the news and they hear about, well, the flu vaccine only covers X amount of strains of the flu, and just because you get the flu vaccine doesn't mean you're not going to get the flu. Well, then that's all true. But at least you'll be protected against some of the strains. And the reason that the measles have popped out is that persons chose not to be vaccinated. And so there's a number of people running around not vaccinated. We had eradicated a disease, and those people were expecting that everybody else got vaccinated so I wouldn't have to get vaccinated. So it just doesn't work that way all the time. And so what you can do to make yourself healthy. And so I would ask my healthcare neurologist, and I'd ask my primary care, why can't? What is it that you think about me that why shouldn't I? Turn it around and ask.
This is regarding the immunizations. If you're on Gilenya, if you've had chickenpox and shingles, do you not need the MMR or the zoster or any of those?
So if you've had chickenpox and you've had shingles, then you're immune to the zoster, herpes zoster, and chickenpox. MMR is a whole nother, right. That's a different disease. And so most individuals were vaccinated as children. Because of the outbreak and because of the potential health threat, the CDC now is recommending that healthy individuals revaccinate one time in their life. But again, I challenge persons that we can draw antibodies and see if you still are protected against that. But those are mutually different diseases. Did that answer your question?
Yes.
Okay.
Hey, I gotta ask. I'm curious, Pat, has any of your patients have expressed to you after having a spinal tap suffering from excruciating back pains, not right away, but months later, like their back is gonna break in half? All of a sudden? It goes away, but then it comes back?
I've not had patients, I've had persons that describe that within a week of having a lumbar puncture. And I've had persons have that last for a couple weeks after that. They describe that, but not someone who has been a month later healed and then is suddenly having back problems. I would be looking for something else. That being said, if you developed an infection in that area and it was a very slow-going infection, then could you develop an abscess that develops a month out? So it's worthy of being examined for that and not passing that off as it's nothing, but it's not highly likely.
It's kind of hard sometimes because even if you try to complain about something, I'd rather not, because them damn co-pays are about $100 to get a damn x-ray. So I just deal with it.
That's different, I think, that's maybe a pinched nerve or something like
right.
you said.
Well, so the thing is, if it was from your lumbar puncture, an x-ray wouldn't necessarily be warranted. So sometimes just a good examination, you can't see your back, but we can.
I know, but it's just, I've had a spinal tap when I was first diagnosed and never had an issue till I did some research last year, and all of a sudden I was experiencing these back pains, like my back is being cut in half right away and put back together right away. So it's really weird.
I'd explore things other than that spinal tap as a cause for that.
Any other around here? I cannot believe we let the guys out and we haven't talked about it.
We haven't talked about sex.
Yay! I was waiting. I'm waiting for one more question.
Are they okay? Yeah. So you're good for another 10 minutes?
Yeah.
You want me to talk about sex?
You just came in at the right time. Men.
Before we start talking about that, I have a suggestion. You said something about the walks and how we need to take it easy because we have balance issues. For some of us who have balance issues, to take someone with us. But if you can't, a friend of mine did give me a good idea regarding it in a jogging stroller with brakes on it. So
that's a good
I'm not
idea.
able to walk my puppy really anymore, so I can take my puppy on it and then walk with it, and in case anything, if I slip or something, I can press the brake for the jogging stroller to stop.
Okay.
I use walking poles. They are amazing for balance and walking distance, so they're very good.
How many persons in the room have ever gone to a sex toy website? How many persons have ever thought about attending a party?
Oh. Somebody didn't invite us.
Yeah, somebody didn't invite us.
Yeah.
Well, mine was years ago.
Yours was years ago. Okay. So what was the most fun thing at that party? What was the most fun at that party?
Finding different things for pleasure.
What people bought?
The items that people bought. It gives you an idea of what went on in their houses.
Oh. How many persons walk into Publix and buy baby oil? Okay. When you walk into Publix and buy baby oil, are you thinking that somebody at the cash register is going to think that you're going to be using that to pleasure yourself or to pleasure your husband? There you go. There you go.
Only when it's KY jelly.
KY jelly.
Only when it's KY, then I think at the register they're raising eyebrows.
No, they're probably thinking that you have an elderly parent at home that's got constipation. Or you have a child at home that you have to give a suppository to.
Ew.
There you go.
We have somebody here.
You were talking earlier about the sexual dysfunction and the lesion part of it. Is there a part in the brain that is the sexual dysfunction part where a lesion actually is? Because you said the lesion, it's like you can't see that.
Well, and sometimes that's a very accurate statement. So sometimes you can't see that lesion that is causing that problem, but your limbic system is part of that, your temporal lobes are part of that, and then, of course, your motor strips are part of that, and your parietal lobe. So it can be a combination, and sometimes you don't see lesions in any of those areas. That can, so it's, the key is, to protect you from getting those lesions, you have to be on a disease-modifying drug. If a disease-modifying drug is if you're still in a relapsing form of MS. But if you have one of those lesions, again, there's ways to trick your brain. And so that's the whole thing. Find a way to overstimulate yourself so it turns on that light bulb. The other thing is, how many persons would think it was odd if I couldn't use my arm here and I went to therapy or I exercised this arm more and more so that it got stronger? Anybody think that's odd?
No,
okay, so if I can't feel down below and I am using rehabilitation aids to help me, why would that be any more odd? We all got here on this earth by that act. That act is extremely essential to our well-being. And so, and it should be pleasurable.
I have a question. I have a suggestion. We should have a party for the women. What do you guys think? I mean, just for, you were talking about different toys, intimacy, just a show of hands. I know you girls are interested. Raise those hands, get them up high. Come on, girls, raise them up high. You girls know you want to do it. Come on, come on. Stand up. I know that's right. I'm going to stand up too.
So recently somebody gave me a book of one of these parties, and here I am in my office going through this book. I'm going to tell you I'm greater than 50 years of age, in case you all couldn't figure that out. And I have 2 children. And I'm looking through this book, and there are things I'm like, what is that? And I'm thinking to myself, I want to have one of these parties just so that someone explains to me, what is that?
I guess the next meeting we're having, we have to share. More questions in the back?
Again, you can get your insurance to pay for the clitoral vacuum pump. Is reimbursable. Okay, that is, and I took the picture out because I was trying to delete slides. It looks like the shape of a mouse, but it has a little piece that comes out, and then it has what looks like your fingernail on the end, and it's a suction cup. And you turn this little device on, and you put that little suction cup around your clitoris. No, I don't. You're not supposed to be able to hurt yourself with it. But what it does is it stimulates that area, brings blood flow into that area so that you're able to have an orgasm.
My question is about the lack of sensitivity when people have it and then don't have it and have it and don't have it, whether it's a man or a woman, and when the partner feels frustrated or the person feels frustrated because there's not any kind of climax or satisfaction. How do you deal with that frustration or disappointment on either party?
That's the importance of mapping, of that body mapping, because intimacy and sexual satisfaction do not mandate an orgasm. I mean, that, there's nothing that takes away that feeling, but you can feel just as close, and persons who don't get that, if they are fully satisfied in every other way, describe the same feeling of being. So you may not feel as well in your genital region, but your leg in a certain part may be more sensitive. Your breast may be more sensitive. They may be less sensitive. So finding those areas that provide that pleasurable experience and having a partner that's willing to then go to those areas and provide you what it takes. And so when you have decreased sensation, sometimes it's just the need for much more stimulation. And so that's the use of vibrators and things, and a much more stimulation than any man can provide. And you can use that in different areas too. So it's a different way of experiencing it. And there are therapists that are out there that's all they do is help persons experience sex.
But what if there's still the feeling of disappointment, that there wasn't satisfaction on somebody's part? I mean, there's lots of feel-good places, but what if they don't get over the top with it and you walk away feeling like, I didn't do a good enough job?
That's where, again, counseling, open, honest communication, because if you don't have an orgasm but you feel satisfied, and or that person does, then that has to be something that is accepted. It's not that you didn't do a good job or that person didn't do a good job. It was a good experience and you felt good, you felt loved, you felt accepted. And so it's a little different, but you shouldn't walk away feeling like you didn't do a good job or that person didn't do a good job. So it's finding that way to be satisfied a little bit differently. And so that may need to be nurtured by someone.
I'm going to say it, but I know because nobody else is going to say it, so I'm just going to say it. Are you including, not to get in your business, but is oral sex included in that?
Oral sex is included in that. So any form of pleasuring yourself or someone pleasuring you. I don't know how you would pleasure yourself orally, but after I said that, I thought about that. But, so yes, that, and so, I have had women who don't enjoy intercourse anymore, but get the same satisfaction with everything else, and then they pleasure their husbands orally. And then it's a win-win situation. And
it goes to okay, I think we're gonna have the last question before he comes again through that door. Okay, but
okay. No, I want to just say that too. Intimacy doesn't just start in the bedroom. It starts outside of the bedroom. You have to communicate. You have to have that respect. You can also hold hands. If that person is affectionate towards you, you will be surprised at those organs. They're going to be stimulated. They're going to be aroused. It's the blood flow. Get that blood flowing, or you're going to enjoy it. Oral stimulation is very good. You can also get movies. And like she said, there's teachers out there. You know, vacuum pump. Maybe you can, you know, next time we have a workshop, maybe someone can bring that. I mean, you know, it's just a suggestion. Right, you can just, you know, demonstrate, you know.
Well, look, the Cialis commercial thinks that you can do it in 2 separate tubs.
Oh, that's right.
I mean, hello. Haven't you seen the commercial? One's in one tub and the other's in the other tub?
Yeah, that's true.
No?
I've seen that.
You know, seen that commercial?
Thank you.
It lasted longer than 4 hours.
Okay, we got, I know, so thank you, Pat. We gotta go.
Firstly, I want to thank you all that are remaining here. Thank you for being here today. All right, thank you, everybody. Thanks for coming out tonight, and don't be cold on your way home.